Welcome to the Endocrine Society's 100 Years of Insulin discussion on building a strong patient-provider relationship. I'm Mark Newman, the editor of Endocrine News, the monthly news magazine published by the Endocrine Society. And joining us for today's discussion are Dr. Grazia Aleppo from Northwestern University, Marguerite Brunner, a patient of Dr. Aleppo's who's lived with diabetes for 57 years, and Evan Stratt, a student at Georgia Tech who's had type 1 diabetes for 11 years. Let's start our discussion with you, Marguerite. Can you tell us about how your treatment has evolved over the years and the important roles your healthcare providers have played in helping you have a better quality of life?
Sure, I can. 57 years ago, I was diagnosed with type 1, and I was 12 years old. I spent 10 days in Children's Memorial Hospital in Chicago, where I learned to draw up insulin and inject it. My mom and I learned the very restrictive diet. She learned to measure everything that I ate on a gram scale. So for 2 years after, she weighed absolutely everything that I ate. If I went to someone's house to play or whatever, she would weigh out my food beforehand and I would bring it. Never ate other than that. I ate 5 times a day, 3 meals and 2 snacks. Very, very rigid schedule, nothing in between, not even Tab, which was the new diet soda. It was a few years before we were finally allowed to have Tab because the doctors weren't quite sure how it would affect blood sugars. And even at that point, we could have 2 bottles a week and only with meals, absolutely nothing other than water in between meals. So I learned the importance of exercise to control my diabetes. And I have, maintained throughout this time, walking and bike riding and swimming, which I enjoy, but primarily to control my blood sugar. I learned to test my urine for glucose, no home blood tests then. So for a long time, a number of years, 4 times a day, I dropped 5 drops of urine, 10 drops of water, and a Clinitest tablet in a test tube. And I compared the color change to the chart and tried to remember to write it down.
Wow.
Very effective, but it was all that we had. So I did all that I could to survive and not do too much damage to my body. So I could benefit from the cure, which I had been assured would be very soon.
Right.
67 years ago.
Right.
I didn't think too much. I thought some about dying early because that had been predicted, but like most 12-year-olds, that didn't bother me. I worried about losing my eyesight, but for all this time, my eyes have remained good. I wanted to have children at some point, but I figured by the time I got to that advanced age, I'd either be dead or there'd be a cure. So as it turned out, I had 4 healthy full-term pregnancies, vaginal deliveries, thanks to the Diabetes and Pregnancy Center at Prentice Women's Hospital in Chicago. So there have been tremendous advances in diabetes care since 1964. Most people have no concept of what it was like then. For me, the first huge difference was home blood testing, huge. It gave me a real sense of what was going on in my body and a better ability to control things, which is always what I wanted. As time went on, I developed hypoglycemic unawareness and my blood sugars became increasingly labile. I would often do 15 blood tests a day, even overnight, setting the alarm to head off hypoglycemic seizures. I teach college level English, and I also worked for the Association of Nurse Anesthetists, the job which required me to conduct meetings and to travel. But in spite of my frequent blood tests and all my efforts, I wound up having to leave that job It just wasn't safe any longer. So I went back into the classroom and I discovered I could no longer teach the 3-hour classes, had to go to the 1-hour classes because my blood sugar would sometimes drop in the middle of a class and I'd leave and wander the campus. So I went to the 1-hour classes instead.
Mm-hmm.
The next technological advancement, which impacted me tremendously, was the insulin pump. The benefits were numerous. I could sleep in the morning instead of having to get up on a rigid schedule because my blood sugar would rise as my insulin levels dropped before that. Also, wonder of wonders, I could eat when I was hungry, not when the schedule told me I needed to eat. It was incredible. But more important than this was that it gave me greater control. And the final technological advancement that has had a profound impact on my life as someone with type 1 is the continuous glucose monitor.
Right.
Oh my gosh, I can see what my blood sugar is always, and whether it's going up or down or remaining steady. If I'm distracted by an activity or by a student or by a grandchild, my blood sugar is dropping, my CGM alerts me. It's amazing.
Right.
You know?
Right.
It will awaken me overnight so that my husband no longer has to give me glucagon injections, which were a not infrequent occurrence at my house prior to that. So I think about what my life would have been like if I'd had a CGM a few years earlier. I likely would not have suffered hypoglycemic seizures. And therefore, I wouldn't have fractured 2 of my vertebrae and damaged my shoulder so dramatically that I needed a shoulder replacement because of injuries suffered during a seizure. I would have been able to continue my job with the nurse anesthetist, which I loved, and also would have been able to teach the 3-hour literature classes that I also loved. And now my CGM works in concert with my pump and it adjusts to blood sugar fluctuations. Incredible difference.
That's amazing. So you have pretty much lived through the evolution of
Yes.
diabetes technology, from
Yes.
testing your urine
Yes.
to having a CGM pump.
Exactly. It's
And all along the way, you've had caregivers that you can trust that have helped you.
I have.
On this.
I have. When I was in Children's Memorial, I met Dr. Matthew Steiner. He was my pediatric endocrinologist, and he was one of the top 2 pediatric endocrinologists in Chicago at the time. He came into my hospital room one day with an armful of books, and he gave them to me, and he said he wanted me to read them and to learn all that I could about this disease because I would have to manage it. He would help me, but it was my disease. That was amazing. It was a time when I felt I was losing control over everything in my life, and he was giving me some control back. It made all the difference and set the pace for me for the rest of my life. Then when I went to the diabetes and pregnancy clinic, and I met Dr. Richard Phelps, an endocrinologist who worked with the clinic. And after I had my second child, he became my endocrinologist, and he was incredible. He listened to me very carefully. He always respected my knowledge of my body and my disease. He knew that I knew it.
Right.
He explained things to me carefully, and we would together discuss my options. So he wasn't very good with technology, however, but he did all that he could to learn about it and pointed me in the right directions. And then when he retired, he referred me to Dr. Grazia Aleppo. And
here we are today.
Here we are today. I tell you, I just marvel at God's providence for bringing me to her. She's just incredible. She knows the technology like no one that I have seen. Absolutely. She understands it. I download my data. She looks at it for a few minutes and she can, just like that, come up with a little tweak that'll solve whatever the issue is that I'm having.
Right.
I could not do it without her. She listens to me. She respects me. She listens to my questions and concerns. She's amazing.
Well, and Marguerite, your story of your life in dealing with this from the 60s to now, and with your different endocrinologists that have helped you, it really emphasizes how this relationship is truly a partnership with your health caregivers. And Dr. Leppo, I'd like to bring you into this so that you could give some advice on building a strong doctor-patient relationship and how you've done this with your patients. You know, Marguerite seems very satisfied, I will say that, and she certainly has given you a great testimonial, but how easy is it to create these relationships with your patients?
First of all, thank you to Marguerite. I am very honored and humbled to see what she has to say. I really appreciate that. So I try to, every time I see a patient with diabetes, new patient, I say, okay, you sought me out. What can I do for you? What are you trying to get out of this meeting, of this relationship, this beginning of this new endocrinology, doctor-patient? Because people come to us not as first doctor, usually we don't have that fortune. They come to us after they go to some other doctor with tertiary center. So I try to understand where they're at, what they need to be accomplished, so they satisfy what they came for. And then I put my detective hat and say, okay, what is that I need to try to get, to understand, to see what's within, what's going on? It's a challenge in A1C, it's hypoglycemia, it's feeling stuck in a particular regimen, fear of complication, whatever they might be, I need to extract that so I can have something as a baseline to where to work with. And then we try to make a plan. And I always introduce two things. One is education, which is a bit tricky with somebody with type 1 for a long time, because as Marguerite was saying, there's been such a huge amount of changes in the last 20, 30, 40, 50 years. But some people don't get the privilege or the chance to actually get to know more about what's new. And it behooves me to do that, to say, okay, I know you learned this a while ago, but there are so many new things out there that make your life much easier. So that's number one, to encourage the patient to say, this is for you, it's not for me, it makes your life much easier. Let's see if we can decrease the burden of the condition. And then I always pitch CGM, technology. This is the number one thing that I say, because truly that is standard of care. You have to have knowledge of your glucose. But you're seeing that really sometimes paralyzes our patients with diabetes on insulin. The fear is of hypoglycemia. And they say, I don't know what to do, if I can go out, if I can't. All these things, with technology, they can really do so much better and really decrease the burden of the disease. So with all these things, I have my little partnership, and then we can set a plan of action and say short-term goals, longer-term goals. Maybe they're not so eager to go to some goals, so I need to gently coax them to get there by engaging them and let them see, this is what I can do for you. You want to try? And I always go at it.
Right. So it's very easy to see that this program it doesn't work one without the other. You have to be in this as a team. You have to be in this together. Yes. Dr. Leppo, do you have any sort of best practices for treating older adults on insulin?
Yes, I do. So even though Marguerite is youthful, her age is going up. So I have a lot of patients who are transitioned to the latter part of their life with diabetes. And these are patients who have been with diabetes for 50, 60 years, 45. And so there are many different challenges that might not be existing with people who are younger. Most of all, if their cognition is decreased, if they are not capable to do advanced technology, if the family is not there, we need to simplify their regimen so they can actually do what they wish to do. I have a couple of patients who are in their mid-80s, 84 and 85, one of them. And this one patient, for example, does not have good memory anymore. And so for this patient, we have a simpler case. The patient wants to stay on the pump for boluses and is doing a tremendous job. But a nurse goes every day to give a long-acting insulin. So there is no chance to go into ketoacidosis if the pump detaches, because the patient might not be able to handle that. So, and the patient has been out of the hospital for 3 years because of it. And so that is huge. Then you got to think about Can we make the diabetes regimen even more simple? Can we do smaller amount of injection, fewer injection, and compromise on the glucose level? Because at the end of the day, you don't want to cause hypoglycemia. You don't want to cause errors in insulin administration either. And so you need to simplify, but keep it safe as much as you possibly can with the help of technology.
Right, right. And Dr. Leppo, have you had any sort of patients that had hesitancy in using insulin, starting insulin?
That is a big issue. So thank you for bringing this up. It's an important question. So patients with type 2 diabetes very often do not realize that insulin is a hormone replacement therapy. I just said to my patient, your bank account is empty. I'll give you a permanent loan. That's insulin. Make it non-threatening, making just this is the natural history of your condition. And of course, we always try to use medication that are oral, some injectable, the newer drugs that do so well also for the heart protection. We try to push that as much as possible. But eventually, the pancreas only has a finite amount of insulin beta cells that produce insulin. So we can't have forever no insulin. I wish that would be the case. And so you might to start basal insulin. And then again, we show the patient your glucose levels in the morning are not reaching target despite you are being on so many different kinds of medication that should help you. So let's try to do this hormone replacement therapy is a physiologic replacement. You don't make any more insulin, you're going to replace it for what you need, whether it is a long-acting insulin, meal time with the biggest meal of the day, or we go gradually. But it's, again, a conversation. It's not an imposition because the patient needs to buy into it. And it works. And actually, what I do sometimes, I do a CGM, a professional CGM, a diagnostic CGM, to show the patient that their glucose do not go down throughout the night. And when that happens, you do know that that is not their fault. They're not eating too much. It's nothing to do with their eating habits or exercise, nothing to do with the patient. The condition is to a place that requires some insulin therapy, and that usually engages them.
Right, that's great advice. Now we're going to hear from both Dr. Leppo and Evan to discuss diabetes self-management, something that Dr. Leppo, you've been really stressing in your discussion here, and the transition from pediatric to adult care, and the benefits of support groups like the College Diabetes Network. So the first question for you, Dr. Leppo, as a patient with diabetes transitions into adulthood, what are some key considerations for the healthcare team?
So that is even a greater important question, because you see, when somebody goes from adult to adult older, the adult, they understand the dynamics of adult practices. When they come from pediatric to adult, it's a whole different world. And so first of all, they tell me the waiting room is full of old people. It's like, I know that, but you're young, you're going to get there eventually. So you got to sort of understand their points. But you also have to realize they're going through a multiple transitions, not just from adult children to adulthood pediatric. It's just that they're doing really a new person, a different team. They might come by themselves or their parents. And then there's also different kinds of approaches because the goals are much shorter. For example, if a patient comes to us is going to college, a lot of things, and Evan will talk about this, I'm sure, it is, do I have a fridge in my room? Do I have glucose? Is the ambulance closed? Do I have a pharmacy? Can I do my prescription? So when patients come to us for the first visit, they usually come with their parents. It's a pretty interesting dynamic. So I say, okay, you're 18 years old. If you don't want your parents, you can stay without them because it's the HIPAA, right? And so I try to get a few minutes with them by myself to get to know what they might not be able to share with their parents in the room with the best intention. Sometimes people don't want to share some things, but also to understand whether they are ready to do for themselves. Because very often the parents do the prescriptions, the refills, the appointments, and all these they need to be ready to do by themselves. And they need to think about short-term goal, one semester, because these schedules change so much. They're not the same from semester to semester. They wake up early, they wake up late, they exercise, they don't, they have a part-time job. And then comes our schedule. We need to be flexible because our schedule are different than the pediatric schedule. We don't have a big team with the patient. It's a smaller team and a faster pace. So we need to teach them how to understand the flow, how to connect with us. And also understand that their schedule, they come home for Thanksgiving, for the spring break, for end of the school, the winter break. So I always have some slot that is frozen, so to speak, to keep for my patients to come the Thanksgiving week. They stay 3 days. One is with me, the rest is with their family between Monday and Thursday. Why? Because you need to accommodate them. The schedule is, they're stuck. They cannot quite choose the schedule. So that's one of the things that we do in our practice. And so I take advantage of that time to try to engage. And then remember, they might leave us in 4 years. So you try to really take them to this transition, keep them as healthy as possible, knowing that they might stay with you for a long time or they might not. And so try to keep them safe throughout this time.
Right. Well, Evan, let's ask you about this. I mean, what has been your biggest challenge with managing diabetes on your own after leaving home?
Yeah, so one of the things for me about going to Georgia Tech was actually that it's close to home. So my parents and I still were able to work as a team, and they've been helping with like the insurance and the supplies and those aspects, which has definitely helped because being a student in college, your schedule is like very busy. So two of the things that I found really challenging were making sure I was eating healthy. Because when I noticed that when I cook for myself, I know the carbs in the food, it's a lot healthier, whereas the dining halls were a little bit more like fast food oriented and not necessarily the best things to eat. And similarly with exercise, making time in my schedule for exercise helps a ton. But when you have classes and stressful assignments, it feels sometimes like you can't take 20 minutes out of your day to take a walk or go for a run. But I've definitely found that the time does exist, and it's mostly just finding the willpower. And then also just living with diabetes, like your level of motivation kind of comes and goes. Like sometimes diabetes gets really frustrating because your pump sites aren't working. And you just kind of don't want to deal with it. And one of the things that's helped with that is that with Control IQ on my insulin pump, when I don't necessarily want to deal with it, it still does. And so there's kind of this minimum level of help that's always there for me. And then the last thing is with all these data analysis tools, it's still really hard to fine tune my basal rates and carb ratios. So there's Dexcom Clarity, which is a wonderful tool, but it doesn't integrate with my insulin pump data. Mm-hmm. And then my insulin pump has Tandem's T-Connect service, but it doesn't have the same pattern recognition as Dexcom Clarity. So there's all this information in different spots, but nothing that has combined it all.
Well, Evan, let's talk a little bit about the College Diabetes Network and other resources and support groups that have helped you manage your diabetes on your own and live a healthy life.
Sure. So when I was starting college, my biggest concerns were definitely about how I was going to navigate that transition to being completely independent. And a lot of it was in terms of like the basics, like how would I tell my roommate that I have diabetes? Or like Dr. Aleppo mentioned, making sure that if something happened and I needed emergency assistance, how would I get that? How would I keep the insulin cold? But luckily my older brother had a mini fridge that I was able to use. And then like, how would I eat in the dining halls and get accommodations for my classes and find a peer support network of other people with diabetes? So really where CDN was helpful is that they have all these resources to help with a lot of these things. And their mission is really to help young adults with diabetes navigate this challenging transition and to thrive while they're in college and beyond. So they were a really great partner for me in this. One thing that I definitely want to shout out was the Georgia Tech CDN chapter. That was a great peer support community, and it was really nice to have like a place where if I just wanted to rant about diabetes, what better place than a group of people with diabetes.
Right.
And we hosted a lot of really enjoyable events. My favorite was always called Diabetes 101. And basically all these students would come and we would just talk to them about the basics of diabetes and kind of like an outreach advocacy combined event. We would also advocate within the campus administration to make the lives of people with diabetes better. So my two favorite things we did were talking with the dining hall staff to get better nutritional information, and then also working with the student health center so that people with diabetes could come and drop off their used sharps. And then another really exciting program that CDN has nationally is their Next Gen Fellows program, which I've been fortunate to be a part of. And one of the things about this is that it used to be just a weekend at one of the major diabetes conferences, but because of the pandemic, they were able to take the program virtual and expand it to 6 months. So really the goal is to jumpstart the passion for going into diabetes as a field for people, for students and young adults who have diabetes. And they do that through professional development workshops, the opportunity to go to one of the major diabetes conferences. So I was able to attend the ADA scientific sessions just a few weeks ago.
Right.
And then through mentorship, so I have someone who I can talk to because I'm graduating from Georgia Tech this fall. So I've been talking to him about what my career plans are, and he's really helped me explore if diabetes is something that I want to go into for my career.
Right. Well, I mean, just hearing this discussion between you and Marguerite and Dr. Aleppo, this has really been quite the tour through the history of not just the technology, but in how people with diabetes have had to adapt to what technology is available in that time period. And especially with you, Evan, you've had the College Diabetes Network that's really been there to support you. And we're going to switch gears just a little bit and discuss the patient resources that the Endocrine Society has available through hormone.org and for insulin access as well as affordability. The Endocrine Society has been a tireless advocate for affordable insulin, advocating to policymakers. And we have several advocacy resources on our site where members can get involved. So Dr. Aleppo, can you expand a little on the patient tools available through the Endocrine Society and where people can find more information?
Absolutely. I'll be delighted. So actually, I participated with the Hormone Network last year to make a CGM toolkit, a guide to really introduce technology to the users. We had a lot of fun preparing for the user, not for the doctors, for the provider, for the patient. It's available to anyone. You can download it. It's great. I have it in my clinic. I print it out, give it to people. Then you also have something for mealtime insulin to understand how mealtime insulin works, the different types, slower, faster, what to expect, how to manage not to avoid hypoglycemia or hyperglycemia. We also have something called like diabetes technology roadmap that tells you what each tool is, from a glucose meter to an insulin pump to an insulin pen to a CGM, to explain to you what these tools do and what might be something you'd be interested in as a user, as a patient with diabetes. That's
Right.
what we have available to the user, to whom wants to go to the website.
That sounds great. Dr. Aleppo, can you talk a little bit about insulin access and affordability and what tools are available to connect patients to affordable insulin? Because that's been a huge issue in the last few years.
Yes, it's been a huge issue. So I had the fortune and the honor to work in the Clinical Affairs Core Committee at the Endo Society for a few years, and I was the chair until just recently. And we worked together to really make this an important part of our mission. And so this year in JCM, the position statement came out from the Endo Society. There really is pointing out specific things to the stakeholders. Number one, they need to make sure that there is a clarity and more transparency in how and why the insulin cost is so high, and why you have this high cost of insulin. Number two, what they really suggested, I hope it will happen, there will be no more than $35 for either sharing of the insulin or copayment of the cost of or copayment for an insulin prescription of $35. They also are trying to, we recommend to cap the insulin amount, the insulin cost amount per month to no more than $100. They also are recommending that there will be more biosimilar, I should say, insulin preparation in the market. So the FDA should really approve more insulin biosimilars so the market has more competition. And five, there should be really significant changes to the payment system for Medicare Part D or Part B, because this affects tremendously the ability of our older patients who have diabetes for 50 years. You know, and now they're on Medicare and have more need to have insulin and a fixed income, and they can't afford to either buy food or insulin. And it's really heart-wrenching to see people cry in your office because they can't afford it. So I applaud in the society and support wholeheartedly this mission to really try to reduce and be at the forefront of this important thing. In addition, there are also some resources. One of them is getinsulin.org. It's a great place to go. So it's a website, online resources put together by the organization called Beyond Type 1, a nonprofit organization for diabetes, supports advocacy and all sorts of other programs. And in that, I actually used it with a patient to figure out what we can do. So you go into this website and you enter the zip code where you're at and whether you're insured or not. And it tells you very simply with some prompts, what can you do to lower your cost, whether it's a voucher, whether it's patient assistance programs, combination of the two. It gives you a ton of information how to really lower your cost of insulin, find options that are not breaking the bank.
Right, that sounds great. All right, I really appreciate this. This has been a great panel. I feel like that you've taken us all on a journey. Marguerite, Evan, Dr. Aleppo, this has been fantastic because it's been a very brief history and how people with diabetes have been managing their care in partnership with great teams of healthcare professionals. So thank you so much. And a big thank you to Lilly, our sponsor, for making this webinar possible. And Dr. Aleppo will be available on Community Connect on August 16th. From 12 to 12:30 p.m. Eastern Time to answer any questions. So please visit community.endocrine.org and join the discussion. Thank you so much for tuning in.